Good evening, Shalab.
Good evening, Dr. Ashish. How are you?
All good?
All good. So thank you for joining in.
Thank you, nahi bhai. No, thank you. So what's the surgery today?
Surgery, it's just it's a basically a soft cataract, just a posterior sub.
Soft cataract.
Yes,
Just a soft cataract.
just a
This is an
soft
experienced
cataract.
surgeon talking. Experienced surgeon. All right, good.
So
Just
now what I've noticed is, the difference between the kind of patients that are coming to our OPDs and they are ready for surgery. I think the mobile phone has made a big difference to the patients being readily, agreeing for surgery. पहले ऐसा नहीं था. दिख रहा है, मुझे तो दिख रहा है, उससे तो would not want to, go into surgery. But now, क्योंकि मोबाइल फोन नहीं देख सकते हैं, तो अगर सिंपल PSC भी है, तो वो रेडी है सर्जरी कराने की. Do you
मैंने सिंपल पीएससी में तो पहले भी तैयार हुआ करता था. इट्स दोज गाइज विद -2.5 -3 नॉट गुड विजन इन दैट सेंस दैट क्लैरिटी नहीं है. पढ़ तो वो ले रहा है बट नो क्लैरिटी इन दैट सेंस एंड दे अग्री वेरी फास्ट एंड दैट टू आयुष्मान भारत में दे अग्री. Not just paid. Ayushman Bharat people agree so fast.
Right. Hello, Ashwini. So, should we start because we are already minutes? Start करें?
बिल्कुल करिए.
Okay, so good evening, everyone, once again, and
Good evening.
I'm Dr. Shalab Sinha, and this is day 3 of the Golden Jubilee series being presented. So this is a young patient has come with a posterior subcapsular cataract, and normally I always sit on the temporal side unless the horizontal axis is the vertical axis, unless it is steeper. Normally the horizontal axis is what is steeper. So using MVR blades, 2 side ports are fashioned almost 180 degrees apart, and I always inject trypan blue under air, put it from one side port and then wash it from the other side port. The reason being is that the trypan blue stains the side port and I don't have to look for the side port incision. So dispersive viscoelastic going inside, and using a spatula I stabilize the globe, and this is a 2.2 atome. I make a groove at the limbus, and then within the groove I enter the anterior chamber, and since it is 2.2 and my tip is 2.4, so the incision is enlarged slightly, and this is a rhexis marker, Dr. Gaurav Luthra's rhexis marker. So this gives a rough guide for how to size your rhexis. So the 26 gauge needle is bent to work as a histotome, and then the anterior capsular flap is raised, and using small movements, the flap is turned onto the anterior capsule, and it is slowly maneuvered in such a fashion that it gives you a circular rhexis. Now here I was finding it slightly difficult to do the rhexis from the right hand. So now I've switched. Sometimes we have patients with very high cheekbones, and you may find it difficult to maneuver the cystotome. So one must learn also how to do rhexis with your left hand. Since you're going to be using chopper in your left hand also must learn how to do other things apart from just use of a chopper. Now, this is the hydro dissection and the hydro delineation. You can see this is a soft nucleus, and it's very important in a soft nucleus to get a good cleavage between the capsule and the nuclear material. Viscoelastic goes in again to fill the anterior chamber before we introduce the phaco handpiece. This is a flared tip with a slight bend, and using the Pinsky hook, I'm going to dial this nucleus multiple times as to free it completely. And then the attempt is made to cartwheel this nucleus into the phaco tip. So what you saw was that the nucleus was cartwheeled into the phaco tip. One has to be very cautious in soft nucleus because one may very easily go into the posterior capsule. So every movement that is done has to be very thought of and deliberate, and one has to be very patient. One cannot be aggressive while managing the soft nucleus or the soft cataract. Many times a soft cataract is even more difficult to do than a grade 2, grade 3 nuclear sclerosis cataract. And again, before I withdraw the phaco handpiece, I always inject viscoelastic to the side port to maintain the anterior chamber. I believe that it helps to prevent the trampoline effect. If the capsule keeps jumping up and down every time one withdraws the handpiece, and also one trains oneself for how to inject viscoelastic from the side port. Should we have a pixie rent? Again, loading the lens into the cartridge, always done by myself. I do not give this to the OT staff. So this is a hydrophobic intraocular lens. So one must, place the optic and then the haptics within the cartridge. Make sure that they are completely within the groove of the cartridge, so that it doesn't get stuck while we are trying to implant it into the eye. Most of my surgeries, almost 99.9%, are done under topical anesthesia. Ask the patient to look at the light, and using the side port to stabilize the eye, the intraocular lens is injected inside the capsular bag. This is a wound-assisted delivery of the intraocular lens. So the leading haptic is in the capsular bag, and the trailing haptic is dialed also into the capsular bag. Since there was hardly any cortex, you did not see me doing any irrigation aspiration before implantation of the lens. So whatever little bit of cortex that is remaining will be removed now.
गाड़ी आई है कि दादी आई? दादी आई जब बुला रहा 2 मिनट के लिए.
Dr. Pallavi, you're audible. Please mute yourself.
म्यूट तो किया था. Just a second.
So the viscoelastic is washed in front of the capsular bag as well as behind the capsular bag. And whatever cortical remnants that there may be sticking to the capsule, they can be hydro, the pressure of the fluid itself will dislodge those cortical fibers that are sticking to the posterior capsule. Normally, I try to remove whatever cortex, loose cortex that is there, so that it gives a good clean surgery.
चलिए बंद कर दिया. मेरा हो गया था. तो
Capsular bag now looks very clean and pristine. Now, irrigation of the side port incisions, basically to seal the wound. It's very important to have a good closure of the side port as well as the main incision. So irrigation of the side port and the main wound from on both sides, so as to give better closure. And one must do it till you get a rigid eyeball. Lens was slightly decentered, so I centered it. So here checking for the tensile, the tone of the eye. And then what you saw me doing was that it loosened the speculum and then injected the intracameral moxifloxacin. Okay, so Dr. Ashish, how would you do this case had it been this patient on your table? How would you manage this?
Except I would have just made one single port, otherwise I would have done just about everything the same.
Only one single side port?
Or one single side port. I've been doing that for about 15-20 years now. I do even my bimanual IA, I do through the main port and the side port, and there is really no problem with surge. So
yeah, so I've seen even Dr. Satyajit also do this. He uses bimanual, but the irrigation is almost always to the main incision, and he angles the irrigation in such a manner that there is no problem with the AC fluctuating.
I have also never had a problem.
Yeah.
And it's just that in my mind, I just have that one single port. That means one less port. That means one less chance of leakage. One less port to hydrate. One less chance of infection going in or coming out. So I've had a decent I mean time on the OT. So I don't make two side ports. Otherwise, I would have done the same. And I also don't use intracameral antibiotics.
Okay. So Dr. Renu asked a question, what are the parameters? Dr. Renu, the parameters are set the same for the soft as well as the medium grade cataract. This wheeling was done in the segment mode, where we remove the segments. So, but yes, if it's a very soft cataract, the suggestion is that the power should be less, as well as the the vacuum also should be less. It should not be 300, 350, 400, because then suddenly everything will come, and so will the posterior capsule. So you can be on the lower parameters for soft cataract. Sudhir, would you like to share?
Thank you, Dr. Salam.
Dr. Sudhir, sir? Or Dr. Jayashree, would you like to say something?
I joined late, so I missed the video.
Oh, cha.
So yeah, I just joined now, so I was listening to the pearls. Yeah, I think you're discussing soft cataract, right?
Yes, soft cataract, yes.
Yeah, parameters, I'll keep it low, definitely.
Yeah. So I was talking to Dr. Sudhir some few minutes back, and he said that it's very important for every phaco surgeon to know their machine. And certainly you know what your machine is capable of doing and how it behaves in the different types of cataract. You will not be able to use the machine to its optimal capacity. So one must always try and change and see how your machine is behaving with every different type of cataract.
Right.
Yes. So soon we will have the surgeons also, not only myself operating. There will be other surgeons like Dr. Ashish and others whom I will request, Dr. Parijat, Dr. Sudhir, and you also, Dr. Jayashree, you should also share your videos, and because the basic purpose of this platform is that I would want everyone, the PGs and the young postgraduates, to see different types of surgeries by different types of surgeons, so that they can pick up the pearls from all the various surgeons. Very important that every surgeon has something unique, and if you can pick up one pearl from one surgeon and one pearl from the other surgeon, it makes you a better surgeon. That's what I feel. So in the coming few days, I will request everyone to give me their dates so that I can plan, and and those surgeries will be shown by the surgeon on whichever date that they would want to present it in. Okay. So anything else you would like to add, Dr. Parijat?
Hello.
Yes.
Yeah,
Yes.
actually,
even I didn't see the nucleus part of it because there was I was just adjusting my mobile. But what I would suggest is that as you have rightly said, that every case you should. What I do is that I see a lot of videos. I'm in a habit of seeing lots of videos on the YouTube, and I change my technique uh, on and off. So in these softer cataracts, I think your was very soft. I think because the way you were discussing it, but softer cataract I prefer because holding is not very good. Nucleus, there is a lot of you can say cheese wiring, and uh, the probe does not the phaco tip does not hold the nucleus very well. So what I do is that I make a central trench, and if I'm able to divide the nucleus in two halves, it's well and good. And if not, then also by just aspiration mode, it comes off. The central trench is important because that helps it to give way to the nucleus. The nucleus gives way easily, and it crumbles. And
Yeah, so
by just
we would like to see your surgery also, if you have a soft.
definitely. And then one more very important thing, I think for all of you, you might be also aware of it, that since these nucleus, they don't, the initial holding is, after impaling the nucleus, holding is difficult. So what I have been doing is that uh, hydrodelineation is required, because that helps it to separate the endonucleus from the cortex. So once the endonucleus is delineated, then holding becomes a little better. So so that helps a lot. So in fact, for all cataracts, first I never used to delineate, but now I've started delineating because it gives a better hold. Because even in moderately dense cataract, sometimes cortex is more. So that also, initial few grips on the nucleus, it slips. So so delineation is a must, and then rest, everything is almost the same. Low parameters and all those things is important. What Ashish said, that surge, sometimes in gravity machine surge is there. So that you have to control on your own by lowering the parameters, lowering the vacuum, and raising the bottle height. Phaco power also should be lowered. So all those things are important.
Yes.
This is all what I have to say.
Thank you. And please give me a date in which you would like to present your any surgery.
I'll definitely do.
Dr. Sudhir?
Whichever date is convenient, I'll just let you know.
Yeah, please. Dr. Sudhir, sir, can you hear me? Dr. Sanjeet Saha. Good evening, sir.
Yes, boss.
Hello. How are you? Would you like to give a few comments?
It was lovely surgery that I enjoyed. And I don't know which machine you are using. Which machine this is?
This is a Boschelom Stellaris PC.
Stellaris. Wow.
Yes.
Best. Okay, so Stellaris is not good for soft cataract because that is a bit the venturi pump.
It's a combined machine, so
okay, you can sit in between. Okay.
Yes.
And that's good. So if there are residents that I don't know, then they should know this basic difference, Stellaris or the venturi pump and other pump. And as he said just now, that cortical cleaving hydrodissection, if you don't know, learn it, and that will help you in everything in phaco. And once he delineates the endonucleus, then the job is half done. And then it becomes small and can hold. And I personally feel softer one, we should use that ball type dialer. So that will help to hold the things on the other side. It becomes little, it doesn't move around here, there. And the power should be minimal as possible. One more point, because now the machines are very fast and it can be in very high power. So better to use the MVR knife for the perfect measurement. Doesn't leak on the side. If it leaks, then it becomes unstable. For
Yes.
the new surgeons, it might be difficult. Better to measure and put exactly the same. Once you know, then anywhere you can do, no problem.
Yes.
But lovely.
Thank you.
Very good way of doing it. And especially for the fellow doctors, it will be very good learning.
Yes. 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 So that is my primary intention, that we must learn from each other.
Very, very good thing. And local people will be getting benefited.
Yes, everyone, whoever joins in can benefit. And these are, because it is being recorded, this will be on the YouTube, and you can go back and suggest to your colleagues or to your
No,
juniors.
thankfully YouTube have so many videos, but this live surgery and the live interaction, that
Yes,
teaches.
yes.
There is a teacher here.
It's very true, very true. So
YouTube, okay, shows the things and edit it, so you don't see the actual points.
yes, very
So
true,
unedited YouTube, okay, but otherwise, when there is something is being done, you see. That's why when you see these conferences, there these surgeries, and
yes,
then you know that who is in how much water.
yes.
That's the point.
So, yes, Sudhi sir, you've joined from your car.
नेटवर्क खराब था,
अच्छा,
रास्ता में थे ना।
अच्छा,
ठीक है सर। हम कुछ सर्जन जस्ट हम ठीक ही बोल रहे थे कि सॉफ्ट कैट जैसे हार्ड कैटरेक्ट की डिफिकल्ट, इसका उल्टा सॉफ्ट कैटरेक्ट इजी ये नहीं है। सॉफ्ट कैटरेक्ट इज समथिंग लाइक ड्राइविंग ए ब्रेकलेस कार।
यस,
कार विद पुअर ब्रेक। तो आप शुरू करोगे कि यहाँ जाके रुक जाएंगे, लेकिन हो सकता है आप अंदर चले जाओ, कैप्सूल को हिट कर दो।
जी।
तो ये एक है, इसलिए शुरू में इसका टेक्निक जो है मास्टर करना पड़ेगा। और ये इसका फार्माकोडायनामिक्स डिफरेंट होगा फ्रॉम योर नॉर्मल कैटरेक्ट।
राइट।
हाँ, वो इस तरह से डिफरेंट होगा कि जैसे आपका जो सॉफ्ट कैटरेक्ट का सिमुलेशन एक हो सकता है, हम हलवा समझते हैं, उसको होल्ड करना मुश्किल होगा, तो आप सक कर सकते हैं उसको पावर से। एक तो वो हो गया। दूसरा, जो भी चीज होल्ड नहीं कर सकते हैं, जो कि सॉफ्ट भी उतना सक्शन भी जिसका नहीं होगा, और क्ले टाइप का गीला मिट्टी की तरह, उसको सक नहीं कर सकते ना, तो वो होल्ड होगा, वो चिपिंग होगा उसमें। तो फिर उसमें आपको दूसरे तरह से जाना होगा। तो जहां पर इतना सॉफ्ट लग रहा है कि आप उसको सक कर सकते हैं, तो आप सीधे पावर कम करके वैक्यूम और फ्लो AFR बढ़ा लेते हैं। जबकि चिपिंग वाले में आपको थोड़ा सा यहाँ पर आपको कोशिश करना है कि अगेन लो वैक्यूम पर करें इसको, क्योंकि ज्यादा वैक्यूम पर करें तो चिपिंग ज्यादा होगा। ये मेरा कहना है कि जितना सॉफ्ट कैटरेक्ट लग रहा है, तो आप क्रैक करने का चांस कोशिश करते हैं, तो मिनिमल वैक्यूम पर करना होगा। तो उसी से एक तरह से मैकेनिकल क्रैकिंग होगा। वो एक हाथ में फेको प्रोब रहेगा, दूसरा हाथ में चॉपर रहेगा, तो मैकेनिकली आप क्रैक कर सकते हैं। तो सॉफ्ट कैटरेक्ट करने से पहले नया जो लोग है, या थोड़ा सा लगता है कि हाई एंड मशीन नहीं है, या फिर थोड़ा अभी उतना नहीं आया है क्लिनिकल ये, तो आप चाहेंगे कि इसको अभी आप ना करें। हम चाहेंगे ग्रेड 3 कैटरेक्ट पर अभ्यास करिए, तो ज्यादा।
Soft is always challenge. Better to use a stop and chop at the beginning, so that you can break in heminucleus, then whatever you can do.
Yes, very true. So we will have Dr. Sudhir as well as Dr. Sanjeet also probably someday presenting their surgical videos. And this is what I want, that the interaction should be there, and we must be able to learn from each other, because learning is a continuous process. Nobody is perfect. No surgeon is perfect. And
exactly,
we must learn from each other. So thank you very much, everyone, for joining in today. And see you again tomorrow at 9:15. Thank you. Good
You're
night.
Thank you,
every day
Salab.
9:15.
Okay, thank you, Salab. Thank you so much.
Thank you, Ashish. Thank you, Jayashree.
Salab, this is every day 9:15.
Yes, sir. Monday, Tuesday, Wednesday, and Friday, Saturday.
Whole 6 days.
All 6 days till the 8th of May. That is, I started on 26th January, birthday of my father,
Okay.
and I'm going to do it till 8th of May. That is the birthday of my late mother. So
Okay.
it will be till 8th of
Good.
May. And then, and it is a Golden Jubilee series because our hospital is completed 50 years.
This is the year I entered medicine.
So 50 years celebration will be after the Lok Sabha elections. And you're all
Just
invited.
I wanted to add one more thing,
Yes, yes.
Dr. Salab, if time permits. Just one of my colleague just now, he's begun cataract surgery, doing phaco recently. So he said that he encountered a rent because he was very casual in soft cataract. So soft cataract, you can't be casual. You always have to be very alert because the phaco probe tends to hit the posterior capsule if you don't, like Sudhir sir was also saying that it can, it's a brakeless car. So your brake has to be in your mind as well on the foot pedal. So you have to be very cautious to control the nucleus.
Right.
That is what I
Tell
want to say.
tell him to put the sleeve almost covering the tip, almost, so that will protect him a lot.
Yeah. Okay.
Yes, good suggestion.
He knew, so he will not be knowing that. He's seeing that everybody is putting it out. So the soft one, it should be just there. The fluid percolates around.
That what you have
then
said,
the
sir, is very
ball pointed chopper will be like a holder. It will be better bet.
Yes, blunt chopper always. A blunt chopper.
What you are saying is very true, sir. For harder cataracts, we expose the tip more, and for softer cataract, we expose the tip less. So that is important point, sir.
Okay,
And
thank you,
ball
everyone.
point chopper will hold that soft nucleus. So it will be holding and it will be sucking.
Thank you, everyone. Good night. See you again tomorrow.
Thank you.
With another interesting case.
Hello, it's great. Daddy is speaking via you. It's good.
Thank you.
All the best.
Good night. Thank you, sir. Thank you. Good night. Good night, everyone.